Is someone sharing their screen?
Yes, please, I'm coming.
Okay, so who is reading for us?
Okay, so please, I'll read the question. Okay, so number one is, which preparation can be used to manage both diarrhea and constipation, and why?
Okay, so is there any preparation that can be used for the management of diarrhea at the same time constipation? And if there is, why can we use it? Any ideas?
Metacellulose.
Yeah, so metacellulose, that's true. So can you tell us how it can be used for diarrhea and also constipation? So, metacellulose is one of the bulk-forming laxatives. Our next topic will be constipation. So, as part of the drugs that are used for managing constipation, we have bulk-forming laxatives. And an example is metacellulose. So, these agents usually are what we call fibers or non-absorbable fibers. So, they are insoluble in water and they are non-absorbable. And basically, they swell up in water and tend to create a lot of pores within the fecal matter. So if you are taking it for constipation, basically they increase the fecal mass by adding up to the bulk and increase the pores within the fecal mass. That allows water to penetrate and allow for easy bowel. So when you're taking it for constipation, the recommendation is you avoid water 30 minutes before and 30 minutes after taking the metacellulose. However, this same metacellulose can also be used for diarrhea. But when you are using it for diarrhea, it's a bulk forming laxative. It's sort of increase the bulk. So when you are taking it for diarrhea, so for constipation, you take it with at least 300 ml of water. However, if you are taking it for diarrhea, you avoid water 30 minutes before and 30 minutes after, because it sort of hardens the stool in diarrhea. So that's why you avoid water 30 minutes before and 30 minutes after. However, if you are taking it for constipation, you need it to swell up in water to increase the pulse. So you take it with at least 300 mils of water. So that's the recommendation when you are taking methyl cellulose. So depending on how you take it, can be used for diarrhea or constipation. All right, let's move on.
Question 2. Which pathogen is the most common cause of diarrhea in children?
Okay, so which pathogen?
Viruses.
Yeah, so viruses. So in terms of the most common pathogen that causes diarrhea in children is viruses. So most of the times you may not need antibiotics. Just your ORS and zinc supplementation may be enough. Okay.
Question 3. Which virus causes the most incidences of diarrhea in children below 5 years?
So which of them?
Rotavirus.
Yeah, rotavirus. That's true.
Question 4. Which virus causes the most incidence of diarrhea in adults?
Okay, so
Norovirus.
which of them? Yeah, so norovirus. Norovirus in adults, rotavirus in children.
Question 5. The rational representation of cholera replacement fluid is A, 1:4:5, B, 5:1:4, C, 5:4:1, and D, 4:5:1.
Okay, so which one?
C.
Yeah, so 541. So 541, that's the cholera replacement fluid. Okay.
Question 6. Metronidazole is effective for all of the following except A, amoebic dysentery, B, gardasis, C, trichomoniasis, D, bacteroides fragilis, and E, Escherichia coli.
All right, so which one are we going for?
E.
Yeah, so E. coli is true. It's effective for all of them except E. coli.
Question 7. Which type of diarrhea does cholera cause? A, osmotic diarrhea, B, exudative diarrhea, C, secretory diarrhea, D, inflammatory diarrhea.
Okay, so which one are you going for?
Secretory diarrhea.
C.
Yeah, so C, secretory diarrhea. So anything that causes the release of toxins tend to do secretory. All right, let's move on.
Number 8. Which type of diarrhea does a patient with lactose intolerance have after ingesting dairy products? A, secretory diarrhea, B, exudative diarrhea, C, osmotic diarrhea, D, inflammatory diarrhea.
Osmotic.
C.
Okay, so osmotic diarrhea. We said whenever you take any osmotically active substance tend to draw water into the gut. So usually this happens in patients with lactose intolerance.
Number 9, which type of diarrhea is associated with blood and pus? A, inflammatory diarrhea. B, osmotic diarrhea. C, motility diarrhea. D, secretory diarrhea.
Okay, so which one are you going for? Yeah, so inflammatory diarrhea, that's true.
Ten, which type of diarrhea is most likely caused by erythromycin therapy? A, exudative diarrhea. B, secretory diarrhea. C, motility diarrhea. D, osmotic diarrhea.
So
C.
yeah, so motility diarrhea. So you said erythromycin acts on the motilin receptors in the GIT, and that will increase peristaltic movement.
11, composition of enterogermina. A, Saccharomyces. B, Lactobacillus rhamnosus. C, Bacillus clausii. And D, Bifidobacterium.
C.
Okay, I'm hearing B, I'm hearing C. So which one is it?
C.
Yeah, so it's C. So enterogermina is one of the probiotics on the market, and it contains Bacillus clausii. So you should know some of the common brand names of preparations on the market. All right, let's move on.
Number 12, WHO recommends zinc supplementation in combo with oral replacement therapy for diarrhea in children. What benefits does zinc offer?
Okay, so what are some of the benefits of zinc therapy?
We said that zinc will reduce the severity and duration of diarrhea, and also it can also boost the immune system.
Yeah, so that's true. So that's very true. What again?
And also helps in the intestinal transfer of water and electrolytes.
Yeah, so that's also true. Any other?
It can reduce stool volume, and it can also restore the brush border function.
Okay, that's also very true. Any other? Okay, so all that you've said is true. So the main thing is reduction of the severity of diarrhea and also the duration. The severity, it does it by reducing the stool volume by 30%, and it also reduces the duration by 25%. And aside this is the main reason, but aside that, he also said it helps with intestinal transport of water and electrolytes. It helps to maintain the integrity of the brush border, and it also helps boost the immunity. So all these are added benefits of zinc supplementation when added to ORS in children. Okay.
Number 13, how to prepare homemade ORS.
Yeah, so how do you prepare?
So for the homemade ORS, say we are going to use 6 teaspoons of sugar and half teaspoon of salt in 1 liter of water. Usually the water is boiled and it's made to cook.
Yeah, so that's true. Mm. So 6 level teaspoon of sugar, then half teaspoon of salt in 1 liter of water, which is boiled and made to cool. So that's how you prepare homemade ORS.
So please, can you come again about how to prepare the ORS?
6 level teaspoon of sugar, half teaspoon of salt in 1 liter of boiled water made to cool. Okay, let's move on.
Number 14. What are the components of the following? A. Hartmann solution. B. Cholera replacement fluid. C. Half-strength Darrow's infusion. D. Commercially available ORS.
Okay, so let's start with the first one, Hartmann solution. What's the other name for Hartmann solution?
Ringer's lactate.
Yes, lactate.
Yeah, so if you don't see Ringer's lactate, it's the same as Hartmann solution. Okay, so what are the composition?
We have sodium lactate, sodium chloride, potassium chloride, and calcium chloride.
So that's true. So there's sodium, there's potassium, there's chloride, there's calcium, and there's lactate. So that's the composition of Ringer's lactate. Okay, the next one, cholera replacement fluid.
Sodium chloride, sodium bicarbonate, and potassium chloride.
Okay, so the 541, which one is the 5, which one is 4, which one is 1?
Sodium chloride is 5, the bicarbonate is 4, and then the KCl is 1.
So sodium, 5 gram of sodium chloride, 4 gram of sodium bicarbonate, and 1 gram of potassium chloride. Okay. The next one.
Half-strength Darrow's infusion.
Hello, Dr. Ishak. Please, did you say 5 grams of sodium chloride and then 4 grams of calcium chloride?
No, sodium bicarbonate. So 5 gram of sodium chloride, 4 gram of sodium bicarbonate, 1 gram potassium chloride. The next one.
Commercially available ORS.
No, they have strength Darrows.
And said the potassium is higher in half-strength diaries
Yeah,
as
so
compared to
basically,
ringgers.
that's true. So basically, it's the same ingredient. Just that you have more potassium in the half-strength derives. So usually, when you check the ringgers, how much potassium do you have in ringgers? How much potassium do you have in ringgers lactate?
4 millimoles per liter.
Is it 4? So the one that is readily available in our system is 5.4 millimole per liter. But if you check the BNF, the one they have is 5 millimole per liter. But the one we have in Ghana here is 5.4 millimole per liter. The half-strength Darrows contains 17 millimole per liter. So in terms of potassium, we have more potassium in the half-strength Darrows compared to the Ringes lactate. However, the other ingredients are the same. Okay, let's move on.
Commercially available ORS.
Okay, so what's the composition? Commercially available ORS, what's the composition?
It contains anhydrous dextrose, sodium chloride, potassium chloride, and trisodium citrate dihydrate.
Exactly. So anhydrous dextrose, you have sodium chloride, potassium chloride, and trisodium citrate dihydrate. So that's the commercially available ORS we have on the market.
Sebis, what's the last component you
Question
said?
5.
Trisodium citrate dihydrate.
Thank you.
Okay.
Question 15. How to assess the degree of dehydration in a patient with diarrhea?
So what are some of the things you want to assess?
There are mucous membranes like the eye, the lips, and also their skin.
Okay, so that's true. So you want to check whether there's dry eyes, there's dry mouth, there's dry tongue, dry lips. These are mucous membranes you want to check to find out whether there's dehydration. So based on what you see, you can categorize or stratify the level of dehydration into a patient who is normal, that is less than 5% water loss. Then you could have mild to moderate, where they have between 5 to 10% and more than 10% severe dehydration. So for someone with normal hydration status, they wouldn't have dry eyes. They'll have moist, and everything will be moist in terms of their tongue, their lips, their mouth. However, for mild to moderate, you have dry eyes. For very severe ones or the severe dehydration, you have very dry eyes. So you can also check whether the eyes are sunken. So depending on how sunk the eyes are, it can also give you an idea that the person is having mild to moderate dehydration, severe, or has normal hydration status. What again can you check for?
You can also check
The
for
degree
low
of
urine.
thirst.
Yeah, so whether they are thirsty, right? So for normal hydration, they drink water normally. However, for mild to moderate, they are always eager to drink. They are very thirsty. For severe dehydration, they are so weak that they can't even drink. So unless you do IV hydration for them. Yeah, so how thirsty and how they are able to drink can also tell you the level of dehydration. What again?
The capillary refill time.
Yeah, so the capillary refill time, right? So ideally, when you look at your nail beds and you press hard on it, what you've done is you blanch the area. So before you blanch the area, you realize the place is reddish. However, after blanching, it turns white. So within 2 to 3 seconds, we expect that the blood should refill the area. So that's what we call capillary refill time. So if it's more than 2 to 3 seconds, then patient is likely to be dehydrated. What again?
How fast the skin goes back after pinching?
Yeah, so you can also do the skin tegel test. So you can check after you pinch the skin to see how the skin recoils back. So if it's recoiling slowly, then it should tell you the patient is dehydrated. So you can do the skin tegel test. What again?
Check the urine output.
Yeah, so urine output as well. If you are dehydrated, the body tries to conserve water. So in terms of urine output, is reduced. So that can also be used. So all these are ways of checking for dehydration. It's very important because it allows you to know how the patient should be managed, whether you do a treatment plan A, treatment plan B, or C. It will depend on the level of dehydration. Okay, let's move on.
Question 16. Which of these antidiarrheal is beneficial in diarrhea secondary to bile acid malabsorption? A. 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 Racicadotrile. B. Loperamide. C. Cholestyramine. D. Cowopectate.
Okay, so which one are you going for?
C. Cholesterol.
Yeah, so cholestyramine is a bile acid sequestrant. So someone with bile acid malabsorption syndrome needs something that will sequester the bile acids to reduce the diarrhea. So you can use cholestyramine in such instance. Okay, let's move on.
Please, can you take that again?
Yeah, so I said it's a bile acid sequestrant. So for patients with bile acid malabsorption syndrome, where the diarrhea is secondary to the bile acid malabsorption syndrome, you need something that will cause the sequestration of these bile acids. So we give cholestyramine, which is a bile acid sequestrant in such instance.
Eighteen. 17. List 5 goals of treatment of diarrhea.
Okay.
So eradicate causative organism if indicated, and also to prevent worsening of dehydration and rehydrates the patient.
Okay, so you want to prevent dehydration, and you also want to replace lost fluids and electrolytes. Okay. What again?
Improve personal hygiene.
Yeah, improve personal hygiene. What again?
Prevent
complications.
Yeah, so to prevent complications like AKI, diarrhea can cause AKI, pre-renal AKI, when you become dehydrated. So you can have reduced perfusion to the kidneys, and that can cause pre-renal AKI. You could also have electrolyte imbalance like hyponatremia, hypokalemia. All right. What again? Any other treatment goal?
To eradicate causative organism.
Yeah, so I think that has been said already. Any other?
To reduce morbidity and mortality, especially in children less than 5 years.
Okay, so to reduce morbidity and mortality, that's true. So if you don't remember any treatment goal at all, as usual, to relieve symptoms, to prevent complications, to improve patient quality of life, to reduce morbidity and mortality. These 4 are usually constant. So if you don't remember anything at all, you should remember this. However, you should know the specific treatment goals, like what we mentioned. Replace lost fluids and electrolytes, prevent dehydration, prevent complications like dehydration, AKI, hypokalemia. You also want to eradicate possible causative organisms. All right, let's move on.
Question 18. According to the revised routine immunization schedule of Ghana, when is rotavirus vaccine given?
Okay, so when do we give it?
6 weeks and 10 weeks.
Yeah, so 6 weeks and 10 weeks. Okay.
19. Match the following to the key below. I. Diarrhea alternating with constipation. 2. Diarrhea plus low-grade fever plus vomiting plus no mucus. C. Rice water stew plus vomiting. 4. Diarrhea plus vomiting plus mucus plus fever plus blood in stool. 5. Diarrhea plus blood plus mucus, entamoeba, irritable bowel syndrome.
Next one, which one are you going for?
C.
So C is right? Irritable bowel syndrome. You have diarrhea alternating with constipation. Okay, so the next one.
B.
So diarrhea, low grade fever, vomiting, no mucus. Which one are you going for? I heard B. Any other answer?
D.
D.
D for dog.
Yeah, so D, rotavirus is correct. Okay, the next one.
B.
Yeah, so rice water stew, Vibrio cholera. Which one are you going for? Diarrhea, vomiting, mucus, fever, blood in stool.
Shigella.
E.
Yeah, so Shigella. Shigella. Okay, and the last one, diarrhea, blood, mucus, no fever.
A.
Yeah, so entamoeba histolytica. Okay.
Number 20. Differentiate between Rotarix vaccine and Rotatec vaccine.
Okay, so what are the differences? Rotatrix and Rotatec.
Is the Rotarix non-valent in the sense that it has one species? It has a 2-dose regime, so you can give it to children, and it's a human attenuated vaccine. Whereas the Rotatec is a pentavalent vaccine with 15 species, and all of which you have 3 dose regimes within it.
Okay, so one of the differences, Rotatrix is monovalent, whilst Rotatec is pentavalent. So that's one difference in terms of the composition. This monovalent, Rotatrix monovalent, Rotatec is pentavalent. What again?
Rotovix has 1 species, and Rotatec has more than 1 species. It has 15 species.
Yeah. So that's the monovalent and the pentavalent. So there are five subspecies of the rotavirus. The pentavalent is for all the five species, while the rotatrix is just one. So in terms of the number of doses, what are the differences?
A Rotavix is 2-dose regime, and Rotatec is 3-dose regime.
Yeah, so Rotatrix is a 2-dose regimen, whilst Rotatec is 3 doses. Okay. Any other difference?
Rotavix is a human attenuated vaccine, whereas Rotatec is a human biovin vaccine.
Yeah, so that's also true. So Rotatrix, you are looking at a human attenuated vaccine, whilst the Rotatec is human bovine reassortant vaccine. So human bovine reassortant vaccine for the Rotatec, whilst the Rotatrix is human attenuated vaccine. So these are the three main differences. Okay, let's move on.
21. All the following are true about acute diarrhea except A. Usually self-limiting. B. Most cases are usually non-infectious. C. Interventions may be limited to oral rehydration. D. It usually lasts for less than 14 days.
Okay, so which one are we going for?
B.
Did I hear B? Or
Yes, sir.
okay, any other answer? Or everyone is going for B? Yeah, so
Yes,
acute
please.
diarrhea, we said it's usually infectious. As chronic, which is all right, let's move on.
Hello, sir, please, we didn't get you.
Okay, so I said for acute diarrhea, it's usually infectious. And we know that usually lasts for 14 days, 2 weeks, and typically self-limiting. So you may not take any medication and it will go on its own within 2 weeks. And in terms of the intervention, sometimes it may be limited to just oral rehydration. Let's move on.
22. All these are true about diarrhea affecting the large bowel except A. Diarrhea is usually watery and of large volume. B. Fever is a common sign of diarrhea from a large intestine. C. Stools are usually bloody and mucoid. D. Campylobacter and Shigella are implicated.
All right, so what are you going for?
C.
Okay, I'm hearing C. Any other answer?
A.
Yeah, so the answer is A. So depending on how the diarrhea presents, it can give you an idea whether it's coming from the small bowel or the large bowel. So for diarrhea affecting the large bowel, is usually caused by invasive organisms. So you have invasive organisms like Campylobacter and Shigella being implicated. And because they are invasive, they tend to destroy the integrity of the GI wall. So the stool is usually blood and mucoid. So you have blood and mucus in stool. And there's also fever associated with large bowel diarrhea. However, the stool volume is reduced, or you have small stool volume and it's not watery. When you compare it to small bowel typically does a lot of watery stool and is of large volume. In terms of the organisms implicated, you don't have invasive organisms there. So fever is also absent, and blood and mucus are also absent. So if you see blood and mucus in stool and it's large volume, typically it's coming from, if it's small volume, blood and mucus in stool, typically from the large bowel. If it's large volume without blood and mucus, small bowel. Let's move on.
23. Drug of choice for Campylobacter-induced diarrhea. A. Ciprofloxacin. B. Metronidazole. C. Azithromycin. D. Tetracycline.
So which one are you going for?
C.
Azithromycin.
Yeah, so the macrolides. So either azithromycin or erythromycin. Okay.
So 24. This type of diarrhea resolves with fasting. A. Inflammatory diarrhea. B. Motility diarrhea. C. Secretory diarrhea. D. Osmotic diarrhea.
D.
Okay. So which one? Yeah, so osmotic diarrhea. He said usually resolves with fasting. So if you ingest any osmotically active substance and you're having diarrhea and you decide to fast for 12 to 24 hours, the diarrhea typically resolves. Okay.
25. Fecal calprotectin is elevated in which type of diarrhea? A. Exudative diarrhea. B. Fatty diarrhea. C. Secretory diarrhea. D. Osmotic diarrhea.
A.
So,
A.
yeah, so exudative diarrhea. So fecal calprotectin, we said, is a marker of inflammation. So whenever you have inflammation, you have migration of these white blood cells, and they can release calprotectin. So whenever it's high, it's telling you there's an ongoing inflammation in the gut. So typically use it for IBD patients. Okay, let's move on.
26. Causative organism of amoebic liver abscess is A. Hepatitis B, B. Wuchereria bancrofti, C. Dracunculus medinensis, D. Entamoeba histolytica.
D.
Yeah, so D. Entamoeba histolytica. So which disease does Wuchereria bancrofti cause? Which disease Wuchereria bancrofti?
Elephantia.
Yeah, so elephantiasis. Elephantiasis. What about Dracunculus medinensis?
Guinea worm.
Yeah, so guinea worm. Or dracunculiasis, guinea worm infection. All right, let's move on.
'27. Extraintestinal manifestations of amoebiasis include all except A. Amoebic dysentery, B. Amoebic empyema, C. Amoebic liver abscess, D. Amoebic cerebral abscess.
Okay, so which one are we going for? Yeah, so A. So we mentioned that amoebiasis can do intestinal and extraintestinal. So intestinal is limited to the gut. Extraintestinal is outside the gut. So you can have dysentery being intestinal. However, it can move to the lungs to cause amoebic lung abscess or amoebic empyema. It can also cause amoebic liver abscess. It can also cause amoebic cerebral abscess. So these are extraintestinal. Let's move on.
28. All the following are true about amoebiasis except A. Majority of cases are asymptomatic. B. Entamoeba histolytica exists in both the trophozoite and the cyst form. C. Asymptomatic patients with amoebiasis should not be treated. D. The trophozoite form is invasive, whereas the cyst form is infective.
All right, so what are you going for?
C.
Yeah, so C. So amoebiasis, majority of the cases are asymptomatic, but it doesn't mean that you don't treat them. So asymptomatic patients should be treated. So that's the false statement. And we also said it exists in two forms, the trophozoite form and the cyst form. So we said the trophozoite form is the invasive form. So it moves outside the intestine to infect the other tissues. So it causes the extraintestinal manifestation. Whereas the cyst form is infective. So that is what is found in stool. So if the person visits the washroom, they don't wash their hands well, they can infect other people with the cyst form. So it's the cyst form which is infective, infective, whereas the trophozoite form is invasive. So the answer is C. Let's move on.
Sir, I was wondering that with the A, that's majority of the cases being asymptomatic. If it's asymptomatic, how will you be able to tell that something is wrong to even treat it in the first place?
Yeah, so when you do stool ARI, you'll be able to find the cyst form of the entamoeba histolytica. But the patient wouldn't be showing symptoms. There will be no diarrhea, there will be no symptoms. However, if you do the stool ARI, you can pick the cyst form. So you just be doing routine. Stool ARI is stool routine examination. So if you are doing it for everyone, you can pick some of these things and treat them.
All right, thanks.
Okay.
29. All the following are intraluminal agents except A. Paromomycin, B. Iodoquinol, C. Onidazole, D. Diloxanine furanate.
Okay, so which one are you going for?
C. Onidazole.
Yeah, so onidazole. So it's a nitroimidazole. So it belongs to the same class with metronidazole. So in amoebiasis, we said, aside giving the nitroimidazoles, the nitroimidazoles are supposed to cater for the trophozoite form. Whereas you give something that stays within the lumen of the intestine. So these agents are known as intraluminal agents, and they are supposed to eliminate the cyst form. So you can give paromomycin, iodoquinol, diloxanine furanate as intraluminal agents. However, onidazole is not an intraluminal agent.
Ideal therapy for symptomatic intestinal amoebiasis. A. Paromomycin. B. Metronidazole, then followed by paromomycin. C. Paromomycin, then followed by metronidazole. D. Metronidazole.
All right, so which one are you going for?
B.
Yeah, so B, metronidazole. So for intestinal amoebiasis, the person is symptomatic, having the diarrhea and all that. You don't just do metronidazole. So you do metronidazole to eliminate the trophozoite form. If you don't give anything to eliminate the cyst form will grow into the trophozoite, and the disease progression will continue. So after the metronidazole for the trophozoite, you would have to follow it up with an intraluminal agent. So you can use paromomycin, diloxanine furanate, or iodoquinol, any of them. Let's move on.
Ideal therapy for asymptomatic. Please, are you talking?
Yeah, you can move on.
So, ideal therapy for asymptomatic intestinal amoebiasis. A. Diloxanine furanate. B. Diloxanine furanate, then followed with tinidazole. C. Tinidazole. D. Tinidazole, then followed with diloxanide furoate.
A.
Yeah, so A is correct. So you'd have to know whether the person is symptomatic or asymptomatic. So the asymptomatic, they only need the intraluminal agent to eliminate the cyst form. They are not showing any symptoms. You only picked the cyst form from the stool area. So you only need to eliminate the ones in the stool. So that's why you give diloxanide furoate. However, if you have trophozoites and you have the cyst form, patient is likely to be symptomatic. So you have to do metronidazole and follow it up with intraluminal agents. All right, let's move on.
32. Preferred intraluminal agent for amoebiasis in pregnancy is A. Nitazoxanide, B. Paromomycin, C. Iodoquinol, D. Diloxanide furoate.
Okay, which one are you going for?
B.
Yeah, so B, paromomycin. So paromomycin is actually an aminoglycoside. So generally aminoglycosides are water soluble. In terms of oral absorption, they have very poor oral bioavailability. So you realize that most of the aminoglycosides are not used orally. They are given either by injection or they have topical preparations. So for paromomycin, it's an aminoglycoside. So for pregnant women, we don't want anything that will be absorbed and cause toxicity to the fetus. So we give paromomycin has poor oral bioavailability. So it stays within the gut and eradicates the cyst form of the entamoeba histolytica. So that's why it's a preferred agent.
So please, in this case, how is it given?
Hello, let's continue.
33. All the following are ways of preventing amoebiasis except A. Chlorine disinfection, B. Avoidance of uncooked foods, C. Iodine disinfection, D. Avoidance of sexual activities involving fecal-oral routes.
Okay, so what are you going for?
Chlorine disinfection, because the cyst form of entamoeba is resistant to chlorine.
Yeah, so that's true. So all these are ways of preventing amoebiasis. Avoidance of uncooked food. You want to make sure your foods are washed properly before eating them. Then it can also be inactivated by iodine disinfection, the cyst form. However, it's resistant to chlorine. Then the cyst form is found in stool. So you also want to avoid any sexual intercourse involving the fecal oral route.
34. All the following are true about Clostridium difficile except A, it's an obligate anaerobe. B, it produces two main toxins. C, it is a spore-forming organism. D, can be treated with IV vancomycin.
All right, what are you going for? Yeah, so why D? Any reasons? Yeah, so in terms of the drug of choice for Clostridium difficile, you can use vancomycin, you can use metronidazole and others. But in terms of the route of administration, it should be oral. So vancomycin IV cannot be used for pseudomembranous colitis because the organism stays within the gut. So you need something that will act locally within the gut. So you want to give the oral vancomycin. However, the oral is very difficult to get around. The one that's readily available is the IV vancomycin. IV vancomycin, you don't inject it for pseudomembranous colitis. They would have to just reconstitute the powder into a solution form, and the patient will ingest it orally. So they'll take in the oral vancomycin that has been reconstituted. So that's how you would manage pseudomembranous colitis if you are to use vancomycin injection. You don't give it IV. All right, let's move on.
Doc, please, did you say the powder has to be reconstituted into the oral form?
All the following can be used in.
Yeah, so I said the IV vancomycin is the one that's available on the market. The oral vancomycin is not readily available. The one that we use for pseudomembranous colitis is the oral, because the organism stays within the gut. So you need something for local effect. So the preferred is oral. However, if you are not getting oral vancomycin, you can still use the injection. But the injection, you wouldn't give it IV, but rather you reconstitute the powder for injection into a solution, and the patient will drink it. So they will take in the injection vancomycin orally. And that is how you manage pseudomembranous colitis with vancomycin injection.
Okay, thank you.
You're welcome.
35.
Answer for the question.
Hello?
Please, someone was asking a question.
I was asking the answer for the previous question.
The answer for the previous question. So we said A, chlorine disinfection. That's the exception.
All the following can be used in the management of pseudomembranous colitis except A. Metronidazole, B. Furazolidine, C. Vancomycin, D. Fidaxomicin.
Okay, so which one are you going for?
B. Furazolidine.
Yeah, so furazolidine, not used for pseudomembranous. Next one.
36. In the year 1999, Rotashield, a rotavirus vaccine, was removed from the market through pharmacovigilance efforts due to the risks of A. Cleft palate formation, B. Cutis aphasia, C. Intussusception, D. Carcinogenicity.
So which one?
C.
Yeah, so I heard C. Into perception. It's true. So Rotashield was the first one to be made. However, they removed it because of the risk of intussusception in the children that were vaccinated. So after removal, that's when Rotatrix and Rotatec were introduced. So Rotashield was the first one, but it's been removed from the market now. Let's move on.
37. What does BRAT diet stand for?
So BRAT diet, what does it stand for?
Does it stand for banana for B? R stands for rice. A stands for applesauce. T stands for toast. And this is a diet that can be used in children.
All right. So that's true. BRAT diet. So the B stands for banana, R for rice, A for applesauce, and T for toast. So basically, this was a diet a lot of the pediatricians were using to manage or to augment the treatment for diarrhea. So it was more like non-pharmacological in terms of their diet. They modified it to the BRAT diet. So they combined banana, rice, applesauce, and toast. And it was showing some benefit in reducing the duration of diarrhea. However, recent evidence doesn't really support the use of BRAT diet. So there is not enough evidence to say that we can use BRAT diet for routine management of diarrhea. It can be considered non-pharmacological as an adjunct. All right, let's move on. Hello.
38. Please, my network went off. Okay, so 38. All the following are parasitic causes of diarrhea except A. Isosporidiosis, B. Entamoeba histolytica. C. E. coli. D. Cryptosporidiosis.
All right, which one are you going for?
C. C.
Yeah, so E. coli. E. coli. All right. Let's move on.
39. The 24-hour stool volume is greater than 1 liter in osmotic diarrhea compared to less than 1 liter in secretory diarrhea. True or false?
False.
Okay. So I'm hearing false. So the 24-hour stool volume is greater than 1 liter in secretory diarrhea, but it's less than 1 liter in osmotic. So the statement is false. It's the other way around. Let's move on.
40. Viral infections and lactose deficiency usually cause osmotic diarrhea, whereas E. coli gastroenteritis typically causes secretory diarrhea. True or false?
True.
Yeah, so that's a true statement. So it's true.
41. Shigellosis and amoebiasis are known causes of osmotic diarrhea. True or false?
False.
Yeah, so that's a false statement. Gala amoebiasis doesn't do osmotic.
42. Inflammatory bowel syndrome causes inflammatory diarrhea. True or false?
False.
Yeah, so that's a false statement. So IBS, irritable bowel syndrome, that's motility diarrhea. Whereas IBD, that's inflammatory diarrhea.
Match the following to the statements below. A. Giardiasis. B. Amoebiasis. C. Salmonellosis. D. Bleeding hemorrhoids. E. Bleeding peptic ulcer. So 43 presents with black tarry stools.
Okay, sorry to do.
E.
Yeah, so E, bleeding PUD. So upper GI bleeding will do dark tarry stools.
44 presents with yellow stools.
A.
So which one are you going for?
A.
Yeah, so gardiasis. Gardiasis dash yellow stool.
45. Presents with greenish stools.
C.
Yeah, so salmonellosis, greenish stool.
46. Presents with red colored stools.
D.
Yeah, so D, bleeding hemorrhoids. So red colored stool. Okay. Is that the last question?
Yes, please.
Okay. All right. So I've also sent you some questions from 2018 GPPQE. I think there were some questions on diarrhea. So should we go through that one or you go through it yourself?
So let's go through it.
Please, let's go through it.
Okay. So I've sent it, so you can share that one.
Hello, please. Can you see the screen?
Yes,
Not
please.
really.
Yeah, I can't see it. Let me see.
Or we read from the page.
And please, is it visible?
No, please.
Hey, then please, I can't share it. So
We can read from the page.
please, I'm having difficulties in sharing that screen.
Okay, I mean everyone has the question, so you can read from 17 think which question starts with the diarrhea? Same question, question 5. So you can start reading from question 5.
Yes, please. So, question 5. A patient presents with explosive, foul-smelling, difficult to flush diarrhea, have lost a lot of weight and feel nauseous. Which of the following medications would you recommend? A. Loperamide. B. Oral rehydration therapy. C. Tinidazole. D. Tetracycline.
Okay, so which one are we going for?
Tinidazole.
Which one are you going for?
Tinidazole.
Yeah, so tinidazole. So if you look at the description, they are saying the patient is having difficult to flush stool. You remember when we were talking about the diarrhea, we told you that the one that is difficult to flush is fatty diarrhea. So you have a lot of fat. And because you have a lot of fat, it's difficult to flush using the water in the water closet. Water and oil do not easily mix. So it's difficult to flush. So that should give you a possible insight to the type of diarrhea. So fatty diarrhea, we said patients on weight-losing medications like Orlistat can have it. Patients with gardiasis can also have it. And we also said typically the stool will be foul smelling. And gardiasis also presents with yellow stool because of the fat in there. It makes the stool appears yellow. So looking at all these, the most appropriate agent for Gardia lamblia, because it's gardiasis. So you can't use tetracycline, you can't use ORS, but you can use tinidazole. All right, let's move on.
Question 6. A toddler presents with acute watery diarrhea, which I'm having okay, so a toddler presents with acute watery diarrhea with vomiting and fever. Other children in the play groups have other children in the group have recently had similar experiences. What is the most likely pathogen? A. Clostridium difficile. B. E. coli. E. histolytica. D. rotavirus.
So which one?
Rotavirus.
Yeah, so rotavirus. So looking at the patient in question, a toddler. So usually less than 5 years, we said it's viral. And the most common viral is rotavirus. Okay.
7. Damage to the intestinal mucosa producing bloody diarrhea describes which type of diarrhea? A, inflammatory, B, osmotic, C, secretory, D, induction.
Okay, so which one? Which one are you going for?
A.
Inflammatory.
Yeah, so inflammatory.
Number 8. Which of these causes of diarrhea is not susceptible to metronidazole? A, viral gastroenteritis, B, C. difficile, C. E. histolytica, D. gardasis.
A.
Okay, so which one? A is what?
Viral
Viral
gastroenteritis.
gastroenteritis.
Yeah, so that's true.
So, number 9. Organisms responsible for most causes of infectious diarrhea include all the following except A. E. coli, B. Salmonella, C. Campylobacter, D. Pseudomonas.
Okay, so which one are you going for?
Pseudomonas.
Yeah, so Pseudomonas usually doesn't do diarrhea.
Number 10. This type of diarrhea occurs when a stimulating agent increases secretion or decreases absorption of water and electrolytes. A. Osmotic, B. Exudative, C. Secretory, D. Hydrostatic.
Okay, so which one are you going for?
Secretory.
Yeah, so secretory is correct.
So, 11. This type of diarrhea is distinguishable from other types because it ceases if the patient resorts to a fasting state. A. Osmotic, B. Exudative, C. Secretory, D. Hydrostatic.
Osmotic.
A.
Yeah, so osmotic is true.
So please, that's all. That's the end of the questions.
Okay, all right. So that's how the typical GPP questions on diarrhea may look like. So after going through everything, you should be able to solve any question you meet on diarrhea. Any questions before we close? All right, so in the absence of any question, we'll end today's meeting. Hopefully another time we'll do constipation. All right, have a good evening.
Yes, please. Thank you, Dr. Aisha.
Have a good evening.